This is page 214. The chapter starts at 213, but it's the objectives page. So introduction. There are many forms of cancer. They form in different body systems. So they're not all solid or solid tumors. There are cancers in the bone marrow. So that would be cancer of the blood, so to say. We have solid tumors. We also have tumors that just grow on the tissues. We have two general types. We have benign versus malignant tumors. Regardless, though, as written on page 214, regardless of the type, whether it's benign or malignant, they are characterized by uncontrolled growth. In the case of benign, there is still uncontrolled growth there, but unlike malignant, they are confined to one area, meaning they lack the metastatic capability of malignant cells. We'll look at a few figures shortly to compare between benign and malignant tumors. So it doesn't pick any age, gender, it grows, all right? So we'll also discover a few carcinogens. It doesn't also pick any ethnicity, economic status. Everybody is, anybody can have cancer, although some people will have a higher incidence versus others. Age is the #1 risk factor for cancer, which is on the next page. Not all cancers are a death sentence, although that's not something you would like to hear, right, as a diagnosis. However, it still has a stigma. So when you hear cancer, you automatically think about death. We automatically think about pain. We automatically think about our family, depending on your status in life, whether you're the head of the family, for instance, you're the sole breadwinner. So you start looking about, thinking about these things. So the last thing you're thinking about is yourself, right? You're really thinking about, what am I going to do now? What happens to my kids? What happens to my partner? So your mind isn't on treatment, on the plan of care. So that would be the least thing on your mind. So all you're thinking about is that you're likely going to die and suffer during the process of dying. Now, this book is old. The statistics written here is 2014. Look at the data here, table 13.1. This was in 2014. So it is now 2020. Of course, the figures are always a year late because we can't publish 2020 statistics because the year is not over yet. So the ACS publishes the data in all states, and they have facts and figures every year. They publish it every April. And they did not miss it this year either, even if besides the in spite of having the coronavirus, they were on time in publishing it. So here is the, do you see the PowerPoint?
No.
Probably
it's
not.
still in the textbook.
Okay, here it is. So this is from the ACS website. You can you can just type the search and type in cancer facts and figures. So they update this every year in April. So this is for 2019. Between this one and the first time I saw this was about 2008. There was the figures here are not the same. Breast wasn't number one there. It was, I think, lung and bronchus was number one. Colorectal was still probably number four. I forgot what was number three. Probably uterine. Anyway, there's an impact in whatever policies the government does. So it really matters who's at the top. So who's the president, although he signs the bills, but of course, as you can see in the political climate today, there's effects here on the nation's health. Okay, depending on the policies that they adopt, who they cover, for instance. Let's say, I hate to be political, but look at the recent Supreme Court ruling, for instance, on discrimination against gay, LGBT. So that will impact the health of that population. So here in 2019, we still have, and this is by gender, so we have prostate and breast for male and female respectively. This is the incidence, okay, the who has cancer. So we have lung and bronchus following second for both genders, and then we have colorectal following on third place, and then we have bladder, etc. So if you look at the top three, it's different with deaths though. So if we look at the next slide, this is now the death statistics, meaning mortality. Now this is not the same people. All right, so this is not meaning that these prostate cancers and these breast cancer patients died. Okay, that this is a different statistic. So here in 2019, these were the number of cases that we know that were reported or collected from different providers. And here are the number of deaths. So these people here didn't die in the same year, or maybe some of them did, but it's interesting to see wherein you have the highest cases, but then you don't have the highest mortality. Okay? Prostate is only following second, as well as breast. So that means whatever we're doing, the breast cancer walk, these are all contributing to, let's say, early, PSA monitoring in the males, for instance, or what the stool-based exams we're doing now, because the recommendations are now different. Used to be in as early as 2016, the American Cancer Society recommendation was still endoscopies and colonoscopies, but then lately they've changed it to stool-based exams now. So the recommendation, because they're finding that people are more reluctant to get colorectal cancer screening because of the test that they're recommending, because it's a full scope. So it's very inconvenient versus just sending a stool sample. Okay, so this will have a reflect in the future. So even if we have these incidents here as high as they are, it's still the top three. So the point is they're making changes to make it easier for people to go for early detection of cancer screening. All right, this is not testable. Okay, I'm just trying to impact the consequence of certain policies especially with regards to insurance coverage, for instance. So these have tremendous impact on all the stakeholders. Of course, we're talking about the American citizens here in general. Okay? Because no matter how we look at it, even though insurance covers these screenings, not all people have insurance, right? So that will make a big difference. Okay, back to the textbook. We have modifiable and non-modifiable risk factors for cancer. Let's look at known carcinogens first. Now, your textbook doesn't have a all-inclusive list. They have it in general. So radiation in general, they just have one. Radiation here includes X-rays, any type of radiation. So gamma rays, X-rays, whatever you're exposed to, either as a patient or as a worker. So let's say you're a radiation tech, for instance, or you're a radiation oncologist. So it doesn't matter, you're exposed to radiation. So that's why they have to wear lead whenever they are working with these types of radiations. Benzene is a known chemical in most industrial plants. We have viruses that can cause cancer. HPV and hepatitis B also is known to cause liver cancer. Sun exposure, so we have melanoma from that. And then tobacco. Tobacco, although it's easy to say, oh, that's going to cause lung cancer, or oral cancer, or throat cancer, laryngeal cancer, it's actually linked to many other cancers unrelated to the upper or lower respiratory tract. Cancer, tobacco has been linked to uterine cancer as well, cervical.
Colon, right?
I'm sorry?
Colon cancer?
Yes, so tobacco has been linked to all sorts of cancer, so it's not limited to the respiratory system.
Professor, can I ask a question about ionizing radiation?
Yeah.
Just like as a rhetorical question. So I have a question. If you were to have cancer and let's say it's the kind that called for radiation, does that put you at risk for future cancers too?
Yes, exactly.
Oh, okay, wow.
So the treatment, yeah, because it doesn't really distinguish between radiation used in the industrial sector versus therapeutic radiation used for cancer treatment. So yes, the radiation that you receive for cancer can be a risk factor for future cancers. Same thing also for the um, chemotherapy. So some chemo drugs have been linked to, because they kill cells, and sometimes they don't completely kill normal cells, and then they will cause further mutations in some cells, and so therefore in that sense they can still create new cancers in the future.
Are there procedures that we use for patients who have had prior cancers, to screen them for other future cancers?
Yes, that's part of
Okay.
the follow-up treatment as a patient, because you've had the risk for cancer, or you've had cancer before. So yes, your risk for cancer actually increases. So you will be monitored.
What about people who had it when they were children? Like childhood cancers. I've heard that children have better outcomes than adults, but
Yeah,
do
you
those
won't
children
have this.
also have increased rates?
Yeah, you won't have the same cancer all over again, because they don't usually carry over as an adult. You may develop another form of cancer as a result.
Okay,
As a result of let's say you have a genetic disposition, or as a consequence of how you were treated. So let's say you received chemo or radiation as a child for that cancer. So in the future, as an adult, you may develop another form of cancer. Did that answer your question? All right. So not mentioned here are other um, terms like oncogenes and suppressor cells. Um, all in all, let me just explain it this way, because carcinogen exposure alone is unlikely to trigger cancer. So meaning, even if you're smoking, you worship the sun, you have never received the hepatitis B or the HPV vaccine, for instance, that doesn't mean you're automatically going to get cancer. There are several factors here. So let's say in the mutation, for instance. So we have something called Proto Oncogenes. So this is not testable. Okay, I'm just trying to explain the risk of how a cancer develops and your chances of developing it. So our body has something called Proto Oncogenes. So they're necessary, especially when have, we're still in the fetal stage and then we're newborns. So our cells are still growing, they're still differentiating. Okay, we're not fully grown to say until we're really teenagers, at least where where all the cells are mature. So during these developmental stages, we have proto oncogenes. So the the best way I can describe it is it's like a gas pedal. So if it was a car, the proto-oncogenes is the gas pedal, meaning it's necessary for cell growth, cell maturation, cell differentiation, right? So it's necessary for a growing body. We also have suppressor genes, meaning suppressor genes are like the brake pedal. So you have the proto-oncogenes, which is a gas pedal. Then we have suppressor genes, which are the brake pedals. So the suppressor genes serve as a check on the proto-oncogenes that they don't overdo it, because they might cause a mutation of the cell. So therefore we have suppressor genes to say, hey, stop it. Okay, that's enough. So if there's a normal balance between proto-oncogenes and then the suppressor genes, that's the reason why you and I right now don't have cancer, because we have a good balance there. But because of this is what they're trying to say here, wherein there has to be another interaction, there has to be another mechanism involved before cancer can develop. Okay, it's not alone that you have having carcinogen exposure alone isn't enough to cause cancer. There has to be an interaction there. One example is the disturbance of the balance between those proto-oncogenes and the suppressor genes. Does that make sense so far?
Yes.
Okay, so there has to be a perfect, let's say all the ingredients must be present before you finally develop cancer, right? And your immune system, of course, plays a good role there, especially your natural killer cells. Those are the bad boys in your immune system. So they kill cancer cells also. So when you have any mutations, they kill it. So that's why when we develop HIV or when we're taking immunosuppressants, for instance, we tend to develop cancer when we're on those drugs. So let's go to non-modifiable risk factors. The two mentioned in the textbook are age and genetic disposition. So age is number one. We hit a certain age, we tend to develop certain types of cancers. They didn't really say how old is old enough, but we do consider older adult to start at 65. So let's stay at 65, and then your risk increases there. So here, advanced age increases the risk for cancer. So the older you are, the more prone you are to cancer. So later when we talk about leukemia, so there's a CLL, chronic lymphocytic leukemia. In that type, because it's a slow growing tumor, and usually it peaks around 70 years of age, but it takes 10 years or more to fully develop. So let's say you get it at 70 and then you have the manifestations when you're 80. Is it worth it to get treatment, suffer chemo radiation to treat it?
Not at that age.
Yeah, that's what I mean. So some cancers develop late, and at that point, the patient will just say, well, I've lived my life, you know, I mean, why do I have, and for what? So how many years is this gonna buy me, or how many months is this treatment, you know, is it worth it to get all the, you know, hair loss, the diarrhea, the pain, the what is this, the immunosuppression that I'm gonna have to go through related to the treatment. So they'll consider that, and they'll just say, you know what, just, you know, screw it.
Professor, I'm sorry, can I ask another question?
Yeah.
I know that this is true for prostate cancer, but I'm wondering if it's true for other cancers, that the older you get it, the slower it grows, because at that point, like, your own body cells are not growing and replicating fast enough, so the cancer cells also don't grow
Yes,
quickly.
that's tumors like that. Let's say cervical, you know, specific to the gender. Let's say, or those that are hormone dependent. So
Like
yes,
breast
that's true.
cancer.
Right. So that's why your risk for breast cancer decreases as you grow older. So same thing if you get the prostate cancer later, the testosterone levels also drop. So therefore, it doesn't have enough to feed the cancer. So yes, it's that can be true.
But is it true for like the cancer that you mentioned, the blood cancer?
Similar.
Okay.
Depending on the type though, because if they are metastatic, your primary tumor may not be your only problem. So the secondary tumors, which are now the metastasis, meaning you may have multiple secondary tumors. So those, depending on where those grow, those might kill you, not the primary cancer. Does that make sense?
Yes.
So it really depends on, well, what type of cancer do you have? Okay, so we have modifiable, sedentary lifestyle and poor diet. Those we can change. Although, you know, the spirit is willing, but the body is weak. So it's easier said than done. Toward the, you know what, well, let's do the prevention now. Can you see the American Cancer Society website?
Yeah.
Okay. So to get to this, just simply type cancer.org. That's the website. So it takes you to the American Cancer Society website. So one of the topics on your blueprint is early detection. So I'm using this because your textbook was published in 2015. So it's technically old because it's 5 years now. So we go to cancer.org, click on the Stay Healthy tab. So if you scroll down, you see this check here. So say, click this one, Stay Healthy. And then under here, you go to this guy here, Cancer Screening Guidelines. And then you'll click that a second time right here, American Cancer Society Guidelines for Early Detection of Cancer. We will only test the first three. So breast, colorectal, and cervical. The reason is for, although we have lung cancer as the #1 mortality, right, on the statistics, and then followed by prostate for the male, there's really no specific, um, there are no complicated instructions. So in the case of lung cancer, for instance, the only screening is a CAT scan. That's it. So you just get a CAT scan, which requires no preparation. That's it. So patient goes for a CAT scan, you see whether or not there's a tumor there. And in the case of prostate, it's simply a blood test and a rectal exam. So the doctor will order PSA, so they draw blood in the lab, and then he puts on a glove, a little bit of lube in there, and digitally examines the prostate. All right, that's it. Unlike here, wherein we have certain guidelines for breast, colorectal, and cervical. Okay, so let's begin with breast. So these are recommendations from the American Cancer Society. Since these are here, if you have insurance, your insurance company must pay for these tests because this is recommended by the American Cancer Society. And so Medicare follows this, and then Medicare pretty much sets the rules for all other private insurance companies. So women age 40 to 44 should have the choice, meaning, do they have to?
No.
Not really, because it's not easy either. When I knew about what they do for a mammogram, I thought it was just a scan. You put your breast up on a plate and then scans. The traditional mammogram, I didn't know that it's like making a panini sandwich that they press on the breast tissue quite hard. Okay, it's like they're flattening this thing, like they're making a waffle,
Very
and
painful.
it's quite painful. So that's why I can just understand, like including my wife, for instance, she's never had a mammogram. But I told her, it's free, and she said, yeah, free to make a panini out of my breast. So that's what she said.
Yeah.
So here, it's a choice if you're 40 to 44. However, look at the recommendation when you hit 45. 45 to 54, you should get one. You should get one every year. The reason for this is why. Why does and then here in 55 or older, it drops down to 2 years, every 2 years. And then, yeah, every 2 years after that. Why the changes in the frequency?
Because the chance of 45 to 54 is high to get a cancer.
All right, so this tells you, just like what I said earlier, so most of these types of cancers are feeding on hormones. So that's why at this point here, 55 and older, you have, your hormones are dropping, so therefore your mammogram frequency drops. Okay, so this would be the highest risk age group, okay, for breast cancer. For colorectal cancer, this changed. I still remember 2015, all the posters in the hospitals for cancer screening was still 50. So now it's 45. So that means based on ACS data, it's hitting younger people now. So people my age is now at high risk for colorectal, but I should be okay. I've had a couple already for other reasons. It's a long story. And the recommendations here, this used to be longer. There were about 4 or 5 bullets here. It used to be visual examination, meaning you have to have a colonoscopy, either sigmoidoscopy or a full colonoscopy. They took that all away, meaning it doesn't have to be a colonoscopy. It can be stool-based, right? Because I guess, based on research, they can still do the same thing. They can see cancer cells in the stool DNA. So therefore, it's not really, you don't have to have a very inconvenient test prep, and then undergo sedation just to get this test done. So it's all you need is just your stool, right? So it starts at age 45 now, and then finally cervical cancer. This was also changing. I remember 2008. This one said, the first bullet said all sexually active women should have a PAP. Now they changed that. They said cervical cancer's testing should start at age 21. Women under age 21 should not be tested. Now, before you say anything, if you've had a pap smear before you were 21, I'm sure that wasn't for cervical cancer screening, right? You had something else That's why you had to have a PAP. All right. So
But I
all
think they
this is
just
saying
recently
is,
changed these
oh, let me finish.
requirements is the other thing.
Let me finish.
Okay.
All this is saying is this is from the website, and this is under the early detection of cancer. So again, if you've had a PAP test before age 21, that was not for early detection of cancer. Is that clear?
Yes.
All right.
Yes.
Yes, Angelica?
I feel like I think they changed the every 3 years thing recently, because up until maybe 3 years ago, I was getting one every year, and then they were like, no need anymore, and I was just like, oh, okay, are you sure? And they were like, yeah, they changed the requirements, but
Well,
prior it was like every year.
It's every year. Well, they make me
again,
every year.
this is the, I mean, these guys are the experts. These are American Cancer Society, and I'm just telling you, this is their recommendation for early detection of cancer. All right. So whatever other purpose you guys are receiving PAPs for, that's not the same as this one. Are we clear?
Yes.
All right. So this is only for early detection of cancer. Of course, if you have earlier symptoms before age 21, yeah, definitely. Okay, so this is just for general population who have no symptoms. Okay, so these are just their recommendation for early detection, and then you have the monitoring. So you start at 21 to 29, and that's every 3, and then 30 to 65 becomes every 5, and then over 65, I mean, because the risk drops, so they say should not be tested anymore. Granted that they've had regular testing in the past 10 years. Here, what about if I put a scenario on the um, exam question wherein the patient had a hysterectomy already? So do they still get pap smear?
Yeah, for their recommended age group.
Read this, please.
Sorry, I was reading the wrong thing.
No, go ahead and read it, please.
Oh, sorry. A woman who has had her uterus and cervix removed, a total hysterectomy for reasons not related to cervical cancer, and who has no history of cervical cancer or serious precancer should not be tested. I was reading the thing at the bottom.
All right, so this is only if the reason for your removal was not related to cancer. All right, so if it was not related to cancer, then of course, no need to test. However, if that hysterectomy was because of a tumor, a cancer, then we continue testing. And then here, all women who have been vaccinated against HPV should still follow the same here. So the HPV is not it's not a bulletproof, okay? It's not a cancer-proof vest. Right? You should still be tested. And
Okay.
I'm only doing the 3.
What's DES? There was a section over there that said, can you scroll up a little bit for the cervical cancer thing? I was just reading it. It said that women who have had DES, but I can't see it anymore.
Okay. All right, so let's go back to here. So that was early detection. Now, to distinguish between primary and secondary prevention, the screening guidelines that we talked about earlier are already secondary. All right, so let me explain. So the screening guidelines fall under secondary prevention because they are, or what are we doing with the screening? Why did we screen you in the first place?
To detect if you have a cancer.
Meaning here, look at look, I'm back to the ACS website. Can you see it?
Yeah.
All right,
Yeah.
so breast cancer, blah blah blah. So what's in here in all 3? What's common? What number? Age. So do you have the risk factor or not?
Yes.
Yes.
Yes, you do. The age is your risk factor. So you reach a certain age. So now you have a risk for cancer. So that's why it fell under secondary. Primary prevention is you may or may not be in that age, but you are avoiding all the known carcinogens or lifestyles due to modifiable risk factors that put you at cancer risk. So let's say examples of risk of primary prevention is you stop smoking, you eat healthy foods, you avoid too much fat, you drink alcohol moderately, you get immunizations. All right, so these are all under primary prevention, meaning you're avoiding the risk factor in the first place. In secondary, including early screening for early detection of cancer, that falls under secondary because now you have the risk factor. You're not avoiding the risk factor anymore. Does that make sense?
Mm-hmm.
All right, let's continue. All right, a few things here. I'll go through this pretty quickly because it's not really testable. Um, so this is how cancer cells grow uncontrollably. There is no contact inhibition. Normal cells, whenever a cell comes in contact with another cell, that is their cue to, hey, it's time for me to stop growing because I've hit the wall, right? So that's how normal cells grow. If the cancer cell, on the other hand, comes in contact with something, he won't stop growing. He will say, get out of my, get out of my face. So it will continue growing, and therefore it will overgrow and never stop at that point. So that's why they look for, okay, I'll find other places to grow. So now they invade um, other organs and then now ride the highway, go into the bloodstream or the lymphatic system or in the lymph nodes, grow everywhere. Another is apoptosis. So this is the definition here is every cell in our body has a pre-programmed um, lifespan, meaning they grow and then they die at a determined rate, meaning let's say if I was God, I would say, okay, Giselle, you're gonna live only up to
Not me.
116. Okay, you can't go beyond 116 years.
Okay,
So
good.
that's apoptosis. The cancer cells don't have that, meaning they can live, as for pretty much indefinitely. I'm not saying they won't die. Yeah, some of them die, but they have no predetermined or programmed cell death. This one also, when your normal cells need to anchor to neighboring cells so that they can get the nutrition. Cancer cells don't have that, so that's why they can grow and flourish in different patterns. Okay. Let me go here. This is faster. Okay. So these are normal cells in the whatever color this is, pink. Okay, and then the yellow are the cancer cells. So here you have anaplasia or no shape, no definite shape. So normal cells have a definite shape, okay, depending on the type of cell. And what do you notice on the nucleus? So the nuclei of normal cells, are they bigger or smaller compared to?
They're smaller.
They're smaller, right? So you can say here, if the cell is cancerous, they tend to have a larger nucleus, making them more aggressive. They eat more, they grow more, and they can invade, okay, because they have a bigger nucleus, meaning the cellular activity of these tumor cells or these cancer cells are way more aggressive compared to normal cells. See, they have no definite shape. They're anaplastic. They also do not serve a specific function. Unlike normal cells, wherein they have specific jobs depending on what cells they are, these guys here do not have a physiologic purpose. They're just here for freeboard and lodging. Um, all right, so to explain metastasis, so this will now be in the case of malignant tumors. So we have primary and secondary tumors. So this is how they do that. So they can now invade nearby tissues. They do so by tapping into the capillaries, into the blood supply, and then from there they can grow. So they'll take that highway, that interstate, and then go to other organs. So now you have a primary tumor and one or more secondary tumors. Now we can tell between a primary and a secondary tumor. Secondary tumor is also called a metastatic tumor, only based on biopsy. So we take samples of each tumor. So let's say we find 5 tumors in Giselle. So we found tumors in her breast, her lung, her liver, her bone, and also in her brain. So we take a biopsy of each of these, depending on what cells appear there. So let's say in the brain, bone, liver, and lung tumors, we found breast tissue. They're all the same. They were all, as well as the breast cancer, they were all breast tissue. So how many cancers does Giselle have?
1.
How many?
One primary.
1.
She only has one cancer. She has metastatic breast cancer, because all of her cancers are all breast cancer. They're just growing in different parts of her body now. Does that make sense?
Yeah.
Right.
Professor, all metastatic cancers are like that, where it's still the original cancer and not.
Yeah, the
Okay.
tissues originate from the primary tumor. If, for instance, we find different cells in different tumors, then they are different cancers.
Even if it did metastasize?
Well, again, the primary tumor can grow in other places, but it doesn't make it a second cancer, meaning it's the same cancer we're dealing with. They're just at different sites now. They have now spread, but it's the same cancer growing in different parts of the body. Whereas you can have more than one primary tumor. So let's say all those 5 that Giselle has, they can be different. Okay, but in order to know that, we have to take biopsies. So if the biopsies show that they are different, distinct tumor cells, and she has more than one type of cancer.
Professor, but you're saying you wouldn't know that until you biopsied them.
Yeah.
Okay.
Because
thank you.
we have to have a biopsy in order to make a diagnosis. Okay, types of tumor, that's the same thing. Okay, staging. TNM classification. We're only doing the staging. We're not doing the grading, okay? Let me explain. TNM, T starts for tumor, N stands for lymph node, and then M is the metastasis. So I'll have one question on the test, because this is international. Whether the tumor is in the breast, the brain, wherever, we use the same thing. And in any country also, so let's say between America and all the way to Russia, China, Southeast Asia, Australia, we use the same staging classification. TNM is universally used. TNM, let's say T, for instance, they will have a number. So T1 to T4, for instance, typically T1, T2, T3, T4. Now, this is referring to the size of the tumor. The T can be subjective. For instance, a T1 in I mean, let's say T4. Okay, T4 is the biggest. So if a T4 tumor in the abdomen, so let's say I have colorectal cancer. So if I have colon cancer, my T4 in colon cancer, is that the same T4 in brain cancer? Is it the same size? Is it?
No.
No, it will be different because you have considerably less space inside the skull versus in the abdomen, right?
Yes.
Yeah, okay, so that's what I mean by the T may be subjective. It really depends where is the tumor. Is it in the brain? So a T1 in the abdomen, in the colon, may be the same size as the T4 in brain cancer. Does that make sense?
Yeah, okay.
Yeah, because you don't have much room, right? So we can't have the same size because otherwise where are you gonna put the brain, right? It'll be oozing out of your nose, right?
Nice picture.
Okay. The N, the T, by the way, is the only one that has an IS. So TIS means in situ, meaning it's not likely to spread because it is encapsulated. There's also a TX or NX or MX. X like X-ray, okay? X is not necessarily good news. X means we have no idea, meaning we're not sure, we haven't found evidence yet whether or not there's a tumor or there's metastasis or there's lymph node involvement. So X means we don't know. All right, meaning we have no evidence. But in N, it would correspond, the number would correspond to the number of lymph nodes affected. Okay, so we can say and then M also the same thing. So how many sites of metastases are we dealing with? So for instance, if I say T1, N2, M3, what does that mean? T1, N2, M3.
N is lymph node involvement, so that means
So if it's T1, what is the size of the tumor?
Small.
Small.
Oh, okay, that's a small tumor. What about the N2?
The number of lymph
So there's
nodes.
2 lymph nodes involved.
Okay, we have evidence of 2 lymph nodes involved, and then M3.
it's
Metastasis.
metastasized.
Okay, we have 3
Breast.
sites of metastasis. Okay, that's simple enough, right?
Yeah.
Yes.
All right. Okay, the oldest acronym for signs of cancer is caution. I don't know how many decades that's been around, but the caution stands for change in bowel habit, bowel or bladder, or that doesn't heal, etc. So here, this will tell you the type of cancer. I mean, most likely type of cancer. So these are, again, early warning signs of cancer. Change in bowel or bladder, so that could be a primary or secondary tumor in the GI tract or in the bladder. A sore that doesn't heal, depending on where is the sore. The sore could be on the breast, it could be in your mouth, it could be on your skin, it could be on your lung. Unusual bleeding or discharge. Well, where is the bleeding? Is it in your nose? Is it in your ear? Is it from your perineum? Is it from your rectum? It really depends on where is that bleeding or that discharge coming from. Thickening of the lump in the breast or any other part of the body. So that's self-explanatory. Where is the lump? Indigestion, difficulty swallowing, that could be either pharyngeal or nasopharyngeal, laryngeal, esophageal, bronchial cancer. Because even if you're not swallowing in your bronchus, if there's a tumor there which can grow. It may obstruct the esophagus. Change in the wart or mole, that's obviously skin cancer. Then nagging cough or hoarseness could be bronchial, lung, or can also be nasopharyngeal. So that is your caution. How is this tested? I'll simply give you as an example of one of these acronyms, and then you tell me which is most likely the type of cancer we're dealing with. Or it could be a select all that apply, which of the following are warning signs of cancer. It may not start with caution, but you get the idea. Okay, I'll just use different words, but that would still be in the same context as caution. Okay, so this is what I'm talking about. So caution is general. Table 13.2 is more specific. All right, so let's say I put this on a multiple choice or select all and apply. I give you the symptoms. Okay, so which is the most likely type of cancer the patient has? All right, then same thing for brain tumor. I give you these kinds of symptoms and so on. All right. Any question for that
No.
caution? So you have here table 13.2. You have this should, yeah, I think they're all covered under caution, except maybe kidney. Oh, well, there's still bleeding here though. Yeah, bleeding, unusual bleeding. Yeah, so that would still be under, yeah, all of them are in caution. All right. The cancer is, most cancers are chronic, correct? They're chronic conditions. However, they can have oncologic emergencies. The emergencies here are related to either the cancer itself or the treatment for cancer. So let's start. For table 13.3, the ones I'm testing are hypercalcemia, you know about, we did pericardial effusion, right? Last semester, pericarditis.
Yes.
Okay, so let's do spinal cord compression, SBC syndrome.
So, Professor, just want to make sure you're not doing cardiac tamponade then.
No, because we already did
Thank
that.
you.
And then tumor lysis syndrome. And there should be there's no hypercalcemia? Never mind then. Okay. Oh no, here's hypercalcemia.
I thought you
Alright.
circled it.
Yeah, okay. So the oncologic emergencies we're testing on table 13.3 are hypercalcemia, spinal cord compression, SBC syndrome, SIADH, and tumor lysis syndrome. So how many is that? 6? 1, 2, 3, 4, 5. No, only 5. Because they didn't put sepsis and DIC here. Okay, so sepsis and DIC is also an oncologic emergency. In fact, it's most common because patients with cancer, cancer patients are prone to infection, right? So they can develop sepsis and then potentially develop DIC. But we did discuss sepsis already as well as DIC in for exam 1, so that should cover us. So how am I testing oncologic emergencies? So same thing, it's signs and symptoms and interventions. So how do you recognize that a patient with cancer is developing hypercalcemia? Signs and symptoms. So I'll give you this in the um, STEM, and then I'll ask you to describe, because which oncologic emergency is this patient developing? Or it could be, I give you the signs and symptoms, but the question will be, what interventions will you include in the care plan for this patient? Select all and apply. That would be these. All right.
Alright.
And then you do that each one. So let's go to spinal cord compression. So the symptoms, of course, if you have spinal cord compression, would be like spinal cord injury. So there will be sensory motor loss here or changes. And then this is your expected treatment. Well, for the case of this one, of course, this one will be assessment for these. And then you'll, of course, institute fall precautions. Then for superior vena cava, patient will have these symptoms here, and these are your expected treatment, and these are your nursing responsibilities. And then do the same for SIADH and tumor lysis syndrome. Now, let's discuss tumor lysis syndrome, because this is quite complicated. There are several causes of death here. So this occurs usually in leukemia or lymphoma. Now, this is not this is not necessarily a bad thing. Tumor syndrome can be good news. The good news part will know that the cancer treatment is working, meaning the tumors are dying. However, the patient may die also along with the tumor, because the patient will have hyperkalemia. This is resulting from any cell. Tumor cells also contain potassium. So when these cells die, they will also spill potassium. Any dead cell will also produce uric acid, okay, because they died. So those will be your two major causes of death here. So the hyperuricemia may lead to acute kidney injury. Hyperkalemia, of course, will cause dysrhythmias and you'll die. Um, so that's why your treatment here is treatment for hyperkalemia and then treatment for hyperuricemia. And then you monitor kidney function, of course, in the process. You monitor cardiac rhythm. All right. So again, this thing here is good news and bad news at the same time. So we'll go, Giselle. What we have good news and some bad news. Which one do you want first? The good news is the treatment for cancer is working. Your tumor's dying. But what's the bad news? Well, the bad news is you may die also, okay? Because now you're having hyperkalemia and hyperuricemia.
Great.
We already talked about prevention. So these are your preventions. I gave you examples: immunization, avoiding, stop smoking, um, alcohol in moderation. Oh, another is chemo prevention. You can do chemo prevention, or let's say what Angelina Jolie did. She got rid of her breast. That's also part of it. I guess surgery would be prophylactic surgery. Another example is of surgery is polyps. Polyps are, I'm talking about colon polyps. They are not cancer by themselves, but they have the potential to develop into cancer cells later in life. So if they're discovered, they are prophylactically removed to, to avoid just pretty much eliminating the chance of cancer development.
Professor, that's an example of the Proto Oncogene, correct?
What?
That could be an example of the Proto Oncogene, like a polyp, because it can become cancerous.
No, the genes are, I mean, you can't even see them. They are in your blood.
Okay, forget it.
Okay? Polyps are already overgrowths in your colon. I don't really recall how they develop, but they are known to develop to turn into cancer.
Right.
So we have immunizations. So if I ask you which cancers are preventable, by vaccination, sorry.
HPV.
All right, HPV, hepatitis B, right?
Yeah.
All right, because we have immunizations against those. Um, okay, here's again some prevention measures. Here's chemo prevention. Secondary, again, these are now the screening. Okay, so these are essentially screening for early detection and management of cancer. And we already did that under cancer.org here. You know how to get to this website, right?
Yeah.
Okay. Um, so we'll skip this one because this is old. 13.4 is old, so we'll use the cancer.org website, and I'm only testing 3. Tertiary is now after you have received cancer treatment. So this is now the subsequent follow-up. So we remember we talked about earlier, Angelica was asking, after you've had exposure to chemo and radiation, you may develop another cancer. So this is now tertiary prevention. Okay, so the focus here now is to reduce the morbidity and mortality after the cancer treatment. All right, so this is now tertiary. My only discussion here is the biopsy. And of course, how we detect cancer is imaging. If you come across markers, let me look at. So this is the biopsy. Okay, that's how we get diagnosis. There's no. Never mind, they have PSA here. Only PSA. Okay, I'll just give you an example. There are something we call tumor markers. Now, if you see it on the NCLEX, they are not used to diagnose cancer. For instance, CEA, or cancer embryonic antigen, is found in pancreatic cancer, um, um, and colorectal cancer, I think. However, they are not exclusively found in cancer. They are also found in non-cancer conditions. Okay, so that means can they be used to diagnose cancer if they are not specific to
No.
cancer?
No.
No. However, because they tend to be elevated in certain types of cancer, we can use them as a basis for evaluating treatment. Meaning, if at the beginning your CEA was high because you have colon cancer, for instance, during treatment, when we're giving you chemo radiation, if the CEA drop, what can you say about the treatment? Again, the CEA levels when you had cancer was high, colorectal cancer, then it's very high. And then the doctor made the diagnosis with CAT scan, MRI, and then we got a biopsy. Okay, we determined, okay, you have cancer. You have colorectal cancer. Now, during treatment, if the CEA levels go down, how is the patient responding to treatment? Is it good or bad?
It's good.
It's good. All right. So again, the tumor markers are not used to diagnose cancer. However, they can be very useful in evaluating response to treatment. Does that make sense? Meaning we have like, yeah, I can say the same for CA19-9, CA125. So we have hundreds of tumor markers. Again, the tumor markers are produced by the cancer cells, but because they're produced not only by cancer cells, they can also be produced in certain non-cancerous conditions. So let's say liver cirrhosis. When you have liver cirrhosis, your CA19-9 may be elevated, or your AFP, alpha fetoprotein, may also be elevated. All right, when in non-cancerous conditions. So that's what I'm saying by they are produced by cancer cells, but not exclusively by cancer cells. So therefore, in that sense, we can't rely on tumor markers alone in order to diagnose cancer. Okay, so let's go to strict treatment now, because we did the risk factors, prevention, we did all that already. All right, so let's go to treatment. So the oldest treatment is surgery. You see a tumor, you remove it. The doctor decides which one to do first, whether we do surgery and then chemo and radiation, or chemo radiation first before surgery. That's not our business. That's the doctor's problem. Of course, surgery only is applicable when we're talking about non-vital organs. We can't remove your brain, right? Although we can remove part of it, but certainly we cannot remove vital organs. So we can only remove non-vitals. So let's say the breast, we can take that out. Part of your colon, yeah, we can take that out. Or your entire colon. That's not really, you can still live without your GI tract. We can just feed you TPN, you stay alive for a while anyway. Right, radiation therapy. For surgery, this is your nursing responsibilities here, because the side effects of the surgery depends on what did we remove. So let's say if we removed your colon, Mr. Wang, what will be the consequence? You have no colon.
I guess the digestion of food and water.
Well, colon doesn't really participate in digestion anymore. That's in the small intestine. Colon only absorbs water.
Right. So I will be losing more water than normal.
All right. Yes, that's right. Because the stool that you're making through the ileostomy now, is it liquid or solid?
Well, sorry.
Yeah, it's liquid. So therefore, yes, the patient will now be at risk for fluid deficit, because constantly you're losing water. So that's an example. So let's say you lost your breast. That should be, well, I'm not saying that's okay, because you lose your breast, that's important for the female, right? But we can reconstruct it, we can give you a new one, maybe a better one, right? We'll enhance it a little bit, different shapes. So that's for surgery. Let's go to radiation now. So radiation can be external or internal. Let me illustrate this. I see the whiteboard.
Mm-hmm.
Yeah.
All right. So we have external radiation. So this is Giselle. Since we started with you, Giselle, let's do you now. So this is the radiation source. Okay. So she's in a room. So this is at the treatment center. So she receives treatment here, radiation. So the source of radiation is here.
Mm-hmm.
This is inside the treatment room. So when she leaves, this is the door. So she goes out of the door, goes home. Is she radioactive?
Yes.
Yes.
No. The
Oh.
radiation was here. She never took it with her. So she was exposed for a while. So the whole time she was exposed, it killed her radiation cell, her cancer cells, along with, a few um, normal cells, because every cell will be exposed. So although we have more precise radiation delivery now, so let's say she has breast cancer, so we radiated it along with, of course, because there are healthy tissue, the tumor is right here, and then the healthy tissues are um, above, around the tumor. So some healthy tissues will be killed as well. So some cells will die today. More cells will die when she goes home, because the radiation will be absorbed by some of the cells there. So because this is external, radiation generally is local, meaning the effects are local, because they are absorbed here in the at the site of radiation. So she goes home, she's fine. She's not radioactive. In internal, it's now different, because now this is Giselle. So let's say it's bladder. Her bladder has a tumor. So the doctor put in some radiation seeds in there. Okay.
Mm-hmm.
Or maybe on her, she also has breast cancer. She's had surgery already. And then there's a small space there where the tumor was. So the doctor also put some applicators there with radiation seeds at the tip. So and then he taped it there. So whether wherever the seeds are, when she goes home, okay, so this is the doctor's office. So she goes out the door, she goes home, she takes them with her. Is she radioactive?
Yes.
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 Yes, so this is the difference between external and internal. So here, she is not radioactive here because she never brought this radioactive material here. It stayed at the treatment center. This one, she brought them home with her. Although these seeds are only radioactive for a while though, they're not radioactive forever, meaning you can't use them for, to make a rocket or, to make a bomb. So it's not. So these are so tiny and they're only radioactive for a short period of time. So maybe 2 weeks to 4 weeks. So she takes them home with her. All right. So that's the difference between the two. Internal radiation can be sealed or unsealed. If it's sealed, like what she's having right now in her breast and in her bladder, these are sealed radiation materials. It's covered. Okay, there's a capsule around the things. So if it's in that case, if it's sealed, it does not enter body fluids.
Mm-hmm.
So that means if it's sealed, who's this? Giselle. Okay, Giselle's urine, blood, feces, saliva, anything wet coming out of Giselle, if it's sealed, is not radioactive. However, if she receives an unsealed radiation either by mouth or intravenously, these things enter body fluids.
Mm-hmm.
So anything wet coming out of her is going to be radioactive. Again, let me summarize. External radiation, the radiation source is at the treatment center. So the patient is exposed to radiation. She goes home. She's not radioactive. She goes about her business. Her side effects are more local. And then we have internal radiation. You take it with you. It can be sealed or unsealed. Either way, the patient is radioactive. But as far as body fluids, because that will change our precautions, because now if she gets unsealed, can she share stuff with other people?
Yep.
Can she? Like,
With
hey, you're gonna use
unsealed?
my
No,
unsealed?
no.
No, because now anything wet, anything she uses, her saliva, she can't even kiss her partner anymore.
Right,
Okay,
right.
maybe if maybe you wrap each other with cling wrap maybe first, and then yes, you can kiss, but pretty much no body fluid exposure, right? Because the body fluids here will be um,
Radioactive.
radioactive.
Mhm.
So she normally, when let's say she normally, wipes her feces in the wall, she can't do that anymore because the feces is radioactive, right? Maybe later after the treatment, she can resume that. You're just nasty, Giselle.
You nasty as hell.
And you're a nurse.
I'm sorry, it was too funny.
All right, so here are I'm not testing the
Professor,
whole thing. This is very complicated. Um, the only,
Professor,
yes,
what about the people who come into contact with the ones who have the unsealed radiation?
yeah. Okay, so we'll get to that shortly.
Okay.
The thing is, it's not mentioned here. Why I don't like the textbook. Anyway, so external radiation, the most frequent complication here is fatigue. Although I said earlier, right, that most complications are local. So this is the only systemic complication here. They can't really explain this. The onset is 1 to 2 weeks and lasts for 1 to 2 months after the end of the treatment. I mean, yes, it can cause some immunosuppression, so there will be anemia, but then some people without anemia still get fatigue though from radiation. So that's something we really don't know um, why they have the fatigue. So that's the only systemic. The rest of them are dependent on the location. So let's say if the radiation was given on the abdomen, then of course you'll have nausea, vomiting. If you have radiation in your neck, for instance, so can you swallow?
No.
No. So you probably will be given a peg tube, okay? Because it'll be very painful to swallow. Another example is, let's say, if you receive radiation to your pelvis, so you may have some uterine problems, maybe some bladder problems. Okay, it really depends on where did the radiation go. Okay, but most of the time it is localized. So depending on, let's say you get radiation on your chest to treat lung cancer. So the effects will be right around the chest wall. All right. So these are some teachings. So because we put tattoos here, they're not really permanent tattoos. They're semi-indelible, meaning these are long-lasting ink. Just tell the patient not to wash them off because the doctor needs that to uh, accurately position the treatment, so we don't miss you know, to avoid unnecessary damage to collateral tissue. All right. We do have immobilization devices. These are made. These are molds that we create just to position the patient a certain way, right? So we can usually they're used for the head. They create molds of your head in a certain position. That way, we put the mold on you. You're forced to assume that position so that we can more precisely direct the radiation. Okay, so this is now our internal radiation. Please read all these restrictions here. I mean, the patient teaching and nursing responsibilities here. For instance, with visiting. If the patient is receiving internal radiation, can they receive visitors unrestricted?
No, it has to be restricted.
Right, so young children, usually below 16, and then pregnant women, of course, cannot visit. So that will also be the same for pregnant nurses. So if you're a pregnant nurse, you can't have a patient with internal radiation. If there's nobody else, then you'll have to wear an apron, meaning all patients, all patient visitors and nurses will have to wear a dosimeter. That's a device that will determine exposure to radiation. It's just a badge that changes color, tells you, oh, oops, you're getting too much radiation exposure. Okay? But take note that that badge does not provide protection. All right, so that only determines exposure. So if you're the nurse here, of course, this patient has internal radiation. It's inside of the patient. Patient is radioactive. Anybody who's going to be all over this patient have to wear a what is this? An apron, right? And you have to be smart about it. So if you need to give medications, so of course you prepare your medications outside. So get them ready so that when you go close to the patient, you have the apron on, and then you just give the medication. So if you're just talking to the patient, then stay away. The rule is about 6 feet at least. 6 feet away when talking to the patient, but no, you can't put an IV 6 feet away or give a pill 6 feet away, right? You can shoot it at the patient, so you have to go close. You can't clean doo-doo 6 feet away, right? You can't. There's no, the selfie sticks aren't very, suited for that purpose. So you can't really, there's some things we can't do from a distance. So you have to wear an apron, a lead apron. All right. All right, I described these already. So that is the brachytherapy is the internal radiation. I already said it's either PO or some are IV. These are examples. These are implanted in the prostate. So this is the prostate. They put seeds. The seeds are so tiny that they don't need to be removed. Okay, they just lose radiation eventually, and then they're absorbed by the body. Well, I'm not saying absorb, but no, eaten. Your macrophages will just eat the seeds because they're foreign objects eventually. All right, so these are now your complications. I mentioned fatigue.
Professor,
Yes.
and you said for both internal and external, the systemic complication that the individual would perceive is only fatigue, correct?
Yeah, only fatigue.
Okay.
All the rest are localized, depending on where did we target the radiation or where did we put the radiation seeds.
Right.
Right. Um, Here, just make sure that you're aware that the radiation, um, especially if it's internal, the um, the cells absorb them. Okay, so some cells die now, more cells will start dying later. Remember, I'm trying to explain tumor lysis syndrome, right? So tumor lysis syndrome may not occur in the hospital. Tumor lysis syndrome may occur at home. You understand that part?
Mm-hmm.
Mhm.
Okay, because they don't, not all cells die today. They'll die tomorrow, next week. All right, so this is now chemo. Chemo can be PO, IV, intrathecal, meaning put in the bone, intravesical, put it in the bladder, intraventricular, you put chemo drug into the ventricles of the brain. So there's different routes, but our most common are PO and IV. Regardless though of the route, just take note that they have systemic effects. I'm not testing the chemo agent itself. I'm just testing the side effects. So we'll skip table 13.6. None of that. I'm testing this one, table 13.7, which is now the complications of chemo. The reason why I'm not testing chemo drugs is on the NCLEX blueprint, and it's also not expected. We cannot give chemo drugs fresh out of graduation. We need certification. So that's a BSN and months of school before you get, and then you take an exam certification and you become a chemo nurse. Until then, you can't give chemo. However, you can take care. You are expected to take care of a patient receiving chemotherapy. All right. So there will be two tables here. This will be one, and there will be more because these are very short. um, you know what? I'm not really sure if there's another one. Table 13.7. So for each of these, the question will always be, of course, your nursing implications. What are your responsibilities when somebody loses their hair? The hair here is not only restricted on your head. Hair is lost all over the body if it's chemo. Radiation, maybe, yes, it's localized. So you get radiation therapy to the chest, you're Italian, you lose the hair on your chest. If it's chemo though, all the hair in your body will be affected. So you can read, please read here what you should do as a nurse for alopecia. You may say, but that's not life-threatening. Well, speak for yourself. It's important for people, let's say females. Not all females have nicely shaped heads, right? We see beautiful women. I see a lot of women who have lost their hair due to cancer. They look beautiful with or without hair. But some people's heads aren't particularly mine specifically. My head is ugly. Okay? I've shaved my head once. I'm never shaving it again.
It's beautiful, Professor. It's not ugly.
Yeah, sure. Bone marrow suppression is one of the most life-threatening complications of chemo because this will cause neutropenia, placing the patient at risk for infection, sepsis, DIC, and death. Nausea, vomiting. So please read these on your own. Cystitis, this one. Mucositis, these are large sores in your mouth. These not only occur in your mouth, but on your throat, in your esophagus, all the way down to your rectum. The GI tract cells are a single layer epithelium. So therefore, they are rapidly dividing. They are affected by the chemo drug because the chemo drugs kill all rapidly dividing cells. So that will include your GI tract. Your bone marrow is rapidly dividing. So that's why these are the targets for your side effects. So unfortunately, all rapidly dividing cells will be affected here, including the hair. So hair, bone marrow, GI tract, these are rapidly dividing cells. So that's why you have these um, side effects. Okay, very unpleasant. Imagine having nausea every single day for a whole week or sometimes longer, because there are acute nausea, there's anticipatory nausea, there's delayed nausea, diarrhea, skin. Again, these are all about rapidly dividing cells being killed. So your platelets here are included. So you have clotting problems. So you institute bleeding precautions here. Neuropathy will put your patient at risk for falls and injury. Um, but it tells you here what to do. All right. I won't read this for you. Okay, that's your job, reading the nursing responsibilities for each one. Any question on this page?
No.
No.
All right, let's go to the next. We're almost done. We discussed the transplant procedure last week, right? The stem cell. Hello?
No.
Yes, we did, right?
Yes, we
Remember,
did.
discuss, yeah, graft versus host, and then we also
Yes.
did
Yes,
Yeah,
we
yeah,
did.
the site, you know, where the site, where the bone marrow was harvested.
Yes.
Yes.
Yeah, we did it in
All right. So we already did that part. And pain management, we already did last semester. So same principle. The only difference is this is now the patient has cancer, so that's chronic pain, but the pain management will be the same. I really don't have questions on table 13.8, so we can skip that. Okay. I think I discussed this one last semester with you guys. The pain assessment, old carts.
Yes.
This
Yeah,
is
you
equivalent to the PQRST.
mhm.
No, it's really and just a different perspective. So instead of PQRST, we have old carts. So this is specific to the elderly patient receiving treatment for cancer or who has cancer. And that's it. We're done. So follow your blueprint. We have um, causes, risk factors for cancer. We had prevention, right? We did primary, secondary, and tertiary prevention. We did caution, and we discussed the early cancer screening guidelines for early detection of cancer from the American Cancer Society website. We did in oncologic emergencies, we had 5. And so questions on that will be, of course, recognize emergency and then your nursing interventions for each emergency. And treatments for cancer now is surgery. And we said it will be, side effects will depend on what was removed. Then we discussed radiation precautions. Going back here to, so do practical, use common sense when we do. You see the whiteboard?
Yeah.
Yes.
So for instance, if we know that the fluids are in internal radiation, if we know that the fluids are radioactive, what precautions will you take? Can they share the same toilet?
No.
So toilets should at
I
least,
thought you
well,
can, but
what
you
if,
have to flush.
okay, so yeah, so that's what I was gonna say, because what if you have one toilet in the household?
Mm-hmm.
So you're gonna have to wipe it down, wipe the seat down. If you're male, you can't stand to pee, you have to sit to pee. That way you don't splash that radioactive urine all over the toilet seat. If you're incontinent, you can't use, or if you're using diapers, that those diapers contain fluids, so radioactive fluids, so they have to be disposed of properly. If your feces is radioactive, so can you afford getting constipated?
No.
No.
That'll be dangerous, right? Because if you're constipated, remember your feces are radioactive. So therefore, the longer they stay there, they will damage your colon. So can the patient take stool softeners to prevent that?
Yes.
All
Yes.
right. Can they, we already discussed they can't share the same utensils. Okay, so the spoon, fork, knives, plates. Okay, will have your saliva with them. Um, so towels, personal items, you can't share.
Mm-hmm.
What else? Oh, washing machine. Yeah, so I'm thinking about things you share at the house. So washing machine, can you include your clothes with everybody else in the house?
No.
No.
Right. Okay. Again, maintain 6 feet away from your household members.
Professor, do you have to run a load in the washing machine like by itself, like the toilet flushing thing?
Yeah, so your clothes have to be washed separately, and then the safe thing to do is after you wash the clothes in there, you have to run the machine empty, one
Mm.
full cycle, to make sure not there are no remnants there.
Wow. Okay. Thank you.
Uh, what else? Can you think of anything else?
What about utensils?
Yeah, I already said that.
Oh, sorry.
Spoon, forks.
Okay. Thank you.
Well, we normally don't share toothbrushes anyway, but just in case.
You clean the sink after use.
What was that, Gladys?
After you spit on the sink, you rinse it properly.
Wash what in the sink again? I didn't get that.
After you brushing the teeth, make sure
Oh, yeah. That one too. Yeah, because there's saliva there, so make
So the
sure.
same thing for showers too, Professor? Like you would have to like run the shower for a little bit after you're finished so that the next person isn't.
Yeah, just to be safe.
Okay. Thank you.
Okay. Any questions? Visitors, maybe 30 minutes a day.
For both sealed and unsealed?
For
Unsealed.
unsealed, maybe 30 minutes, and then for sealed, we can extend that to 1 hour.
A day. Okay. Yeah.
Yeah. So let's specify here. So this is unsealed, 30 minutes, and then maybe 3 feet is okay. No, it has to be 6 feet because this is unsealed. Yeah, you can stay shorter because this is more dangerous. It's unsealed, so there's more exposure to visitors. So 30 minutes a day, and then stay 6 feet away. For sealed, you can stay longer, up to an hour, so that's 60 minutes, and you can stand closer, 3 feet. This is more risky. But in either case, no visitors less than 16, no pregnant women,
So they would
So
have to sleep in like
this
a
will
different.
also apply to the caregiver, all right? So this 30 minutes, this not only for visitors, this is also for the nurse.
Mm.
So you have to take this into consideration. So for these times here is your total per day. All right. So can you have multiple radioactive patient assignments?
No.
No.
No, you should only be limited to one because that will add up.
Mm.
Okay, that's not 30 minutes per day per patient. That's it for the day. All right. So you should have only single assignments. What were you gonna ask, Giselle?
So, for example, let's say if your partner then unfortunately has this, you're not able to sleep with them in the same room, right?
No, you have to wait. Yeah, you have
Yeah.
to. Yeah, there'll be no. Yeah, absolutely no sexual contact, even with a condom. I mean,
I
condom.
mean, like sleep, like me sleeping, like me sleeping next
Oh,
to
in
someone
the
right next.
same room? Yeah, no, you can't because it's um. Well, you can be in the same room, but far. That would be
Right,
separate beds.
right. It would have to be like that. Okay.
All right, that's it, guys. That's for cancer.